A cleft lip and palate is a congenital deformity with an incidence of 1 in 750 live births. And the basic aim of the management is to integrate the child back in the society with good confidence and a decent speech and cosmesis without any functional disability. So to that, we need a team. A surgery can be performed alone by a surgeon, but when we are talking about a deformity which needs a multimodality approach, then we need to have a team. A team should include a cleft surgeon, could be a plastic or a maxillofacial surgeon, a pediatrician trained in taking care of the cleft, a anesthesia team trained in cleft surgery, a periodontist, an orthodontist, prosthodontist, ENT surgeon, and a speech therapist, and a geneticist. Now, the most important thing in management of clefts is timing of the cleft surgeries to have a satisfactory outcome. To summarize this, I've just put all the list of surgeries that need to be done. So the lip repair and primary rhinoplasty should be done at 6 months, and so on. I'll be dealing with each of them separately. A lip repair and a primary rhinoplasty. Now, when a child presents to us at an early age with a primary cleft lip and palate deformity, the child is not able to feed. The problem is oronasal regurgitation. Whatever the child tries to feed, it automatically comes out of the nose and he cannot swallow the milk. So the most important aim of correcting this condition is to enable the child to have a lip seal. Of course, cosmesis is important, but also achieve a seal, that is function. So we need to achieve a good function so that the child can develop a seal and be able to breastfeed or feed on a nipple. And the patient should also be cosmetically satisfactory outcome should be given. And the age recommended is 6 months, and every surgery which I'd be mentioning is definitely debatable. 6 months is a decent time in terms of safe anesthesia, number one. And since all these surgeries are elective, so safety is definitely a concern. So as per the rule of 10, 10 grams of hemoglobin is what is needed, and the child should be more than 10 pounds of weight and more than 10 weeks of age. This is what Millard has described. And usually by the age of 6 months, the anatomic landmarks, what I'm talking about is the skin landmarks. When we do a lip repair, we put a lot of landmarks on the skin where we plan to make our surgical incisions. These landmarks are more pronounced and more clearly visible at the age of 6 months. And the muscle, which is the external fibers of the orbicularis oris, are decently developed so that we can re-establish the muscle so as to give the child a better function. So all this can be achieved at the time of 6 months. So there are centers and there are controversies which say that the repair can be done as early as 3 months. Now that's a subject of controversy, but we follow a protocol of 6 months age for lip repair. Now this is the same child 3 days post-operatively, a picture of the same child. So what we've achieved here is a decent, cosmesis. The child looks absolutely different. We've achieved a good length of the lip, the nasal alar groove, and the nasal sill. Cosmetically, that looks good. Now, the same child, after 4 years, as the growth progresses, we need to establish certain landmarks, that is length of the lip. Now, the length of the lip is measured from the nasal sill to the highest point of the Cupid's bow. If that is achieved mainly by repositioning the muscle segments in continuity with the non-cleft side. Cupid's bow is established in this patient. Like you can see, the alar facial groove is good and the nasal sill is good. The next surgery that follows is the palate repair. The aim of the palate repair is to achieve good speech. There is no cosmesis in this. It's purely functional. And the idea is to seal the oronasal communication and to achieve good speech. So again, this is an elective procedure which is to be done with utmost safety because the risk of blood loss is high. We are dealing with a very minimal work area and a compromised airway. The children have extremely sensitive airways when we're talking about 9 to 10-month-year-old child. They're very reactive. And when we put this Dingman mouth gag for more than half an hour to 1 hour, there's a risk of airway edema in the post-op. So 9 months is considered relatively safe. Anything above 9 months is what is the current recommendation for palate repair. So the most important thing about this repair is that the cleft has to be closed before the child starts babbling. The success of a palate repair depends purely on the speech. So before the child babbles, the palate has to be closed. So once the speech is lost, there's nothing much we can achieve after that. And once the palate is repaired, the speech therapy should start as early as 2.5 years. And what we usually tell the parents is that when we repair a palate, we re-establish the soft palate musculature together. And it's like somebody with a fractured limb, which is immobilized for a long time. And once the cast is out, we advise active physiotherapy so that the muscle movement is back. Now, the same translates to the cleft palate. Now, a child who has never been using his soft palate muscle, when we reposition the levator sling, has to start using it only when his speech is going to come back. So this is a picture showing a anatomy of the cleft and a non-cleft side. The cleft side, the levator villi palatini and the tensor sling moves straight towards the posterior nasal spine, whereas the normal side goes right across. So our aim of doing a palate repair is to detach the muscle attachment from the posterior nasal spine and reorient the levator sling. So every time the child speaks, the muscle pulls the soft palate up. And at the same time, a soft palate has to be pushed back. When the soft palate moves back, the space between the velum and the posterior pharyngeal wall is decreased, which gives in minimized air escape. Now, I put this little bloody picture here basically to highlight the amount of raw area that's left on the lateral aspect of the cleft. So when there is a wide cleft palate, like I've shown in the slide before, the main aim of the surgery is to close the primary cleft, that is in the midline. To achieve that, the mucoperiosteal flaps are raised, mobilized medially, and closed in a tension-free manner. Now, when we do that, it's going to leave behind raw areas on the lateral segments. Now, these raw areas on the lateral segments are going to heal secondarily or by a scarring. Now, that is what causes significant transverse growth discrepancies as the child grows. Though we achieve good speech, we are losing growth as a child progresses. So this is what we call unfavorable and unpredictable sequelae of a palate repair. One is velopharyngeal incompetence, a mid-phase hypoplasia, and transverse growth restrictions. So as a child completes his lip and palate surgery at 6 months and 9 months, we wait for some time for the child to develop his speech. We advise him speech therapy starting at the age of 2.5 years, and it goes on for 3.5 to 4 years. Now, that is when we recall them to assess their speech. At that point, we assess the speech by either direct examination, or we can take the help of the ENT surgeons to do a video fluoroscopy to see the movement of the soft palate and see if the child has got any velopharyngeal incompetence. Now, to understand that, we need to have a simple idea what is velopharyngeal competence. Now, for anybody to have a good competence, the lateral pharyngeal walls have to move medially, and the posterior pharyngeal wall has to come anteriorly, and the soft palate has to move up. So a velopharyngeal competence, it's a sphincter mechanism. When all three things happen, that's when phonation is much better. Now, what happens in a cleft palate child is that if the palate repair is not satisfactorily achieved, the soft palate musculature can be weak. And if the soft palate is not pushed back adequately posteriorly in the surgical technique, they can be escaped in air. Like the two pictures I show here in the slide, the one is here where it's a normal condition where the air is coming at here and there's no escape of air because the soft palate is touching the posterior pharyngeal wall. Whereas in a cleft palate scenario where the soft palate is short, there is escape of air and the child might present with a hypernasality or the nasal twang. The simplest way we clinically diagnose velopharyngeal incompetence is to ask the child to count 1 to 10, and also we can ask them to say some words where when the tongue hits the soft palate, like ask them to say Coca-Cola or say khana khana hai, and that's when the nasal twang or the hypernasality comes up, and it's easily clinically diagnosed, and then we plan to go ahead and do a pharyngoplasty. Now technically that's done by doing a superiorly based pharyngeal flap, and the timing of the surgery is 4 to 5 years. So that's about pharyngoplasty. Now the next surgery is lip nose revision. Revisions are done at the age of usually they're done at 6 to 7 years, but there is no fixed age of doing a lip nose revision. It depends upon the patient's perception, or it can depend on the parent's perception. So it can be done right away at the age of 4 years or 5 years, or whenever the parent feels that the repair is not satisfactory. And most often when the children go to the school, they are teased or made fun of that the nose is not good. So they come back to us, and that's when we just do a bit of tinkering around the lip and lengthen the lip, or revise the scar, or reposition the ala, or achieve the lip length. So 6 to 7 years is the usual one, but it can be done at any age. Now, this is what alveolar bone grafting, that's an important topic. And that's when most of the cleft patients come to the Department of Orthodontics and Periodontics. And we need a clear-cut understanding of this. So now we've repaired the cleft lip and the palate, but the alveolus still remains as a cleft. So now that's a bony defect. So in the early days, like early 70s and 80s, there were surgeons who have tried to close the cleft alveolus primarily by putting a bone graft at the age of 6 years. But then the growth of the anterior maxilla, which is usually stopped by 6 to 7 years, it has considerably restricted after that, and there was no growth. So gradually the bone grafting had from primarily it moved to a secondary, and it's now it's called a secondary alveolar bone grafting, which is done at the age of 9 to 11 years. Now, why we do it at 9 to 11 years? We have certain aims for this. Now we have a bony cleft which is communicating to the nasal cavity. So we have to close the nasal mucosal defect, which is here, with the gingivo-periosteal flaps and the nasal mucosa. So the nasal cavity is separated from the oral cavity, and the pocket which is created there is filled with the bone graft from wherever it's harvested. And the idea of putting the bone graft is that we are putting the bone graft so that the permanent canine erupts into that. Now, a very simple concept I want to highlight here is that anywhere in the body, when we put bone grafts, they will only survive if there's a purpose for it. Let it be a bone graft in the nose, or there's a bone graft in the alveolus, or anywhere. Graft will survive only if there's a purpose. That's a take home. So the next point is periodontal stability. So when we put a bone graft, the adjacent teeth stability is maintained. And when the bone grafting is done, the cancellous bone is pushed all the way up to the alar base, and all the way up to the piriform rim. It's somewhere here. So these children will have a depressed alar base. So when the bone graft is pushed up, so the alar base is slightly lifted up. So we counsel the parents before that there will be slightly visible change in the post-op. So a good preoperative documentation will definitely help them. And finally, so far we are dealing with a two-piece maxilla. So because the right and left segment are dominant and a small segment. Now, when we put a bone graft, the maxilla is going to be in one unit. So it makes things easier for the orthodontist to move the teeth here and there, and also for the surgeon to make osteotomy and move the maxilla as a one unit. So this is the OPG of a child with an alveolar cleft. You can see the cleft is on a radiograph. It's quite big. Clinically, what appears is it's actually small. It's only the tip of the iceberg. But when the periosteal flaps are raised, the defect is quite big. And what I always suggest is the success of bone grafting always depends upon the volume of the bone graft we put and how well we close the defect. So if the volume is good, if it reaches all the way up to the pyriform rim and we achieve a good, tight, watertight closure without the graft being exposed, that's when we get a good satisfactory result. So the upper dental age limit of performing a SABG is that if we assess the root formation of the canine. So if half to 2/3 of the root formation of canine is done, then we are good to go with a SABG. So from the periodontist point of view, I would say that the arches should be expanded, especially the anterior crossbite, how much ever is possible, should be corrected. At the same time, should not overcorrect so much that the mucosal flaps over the, it shouldn't lead in a fistula formation anteriorly. So we should expand the arches adequately only for the bone graft to sit in there and not to create a fistula. And pre-surgical orthodontics as much as possible to correct the transverse discrepancy. And we should make sure that all removable orthodontic appliances should be removed prior to surgery. I'm sure the anesthetist would make sure of that, but as a periodontics team, we should make sure that everything is removed. So one more thing I want to highlight is that the bone graft is like a cement. Once we put in there, there is no expansion after that. We cannot achieve any transverse expansion after the bone graft is placed. So whatever expands before, it's done. The choice of bone graft, why I wanted to speak about the timing, choice of bone graft and timing is that in a growing child, the cancellous bone can be harvested from anterior ileum with a trapdoor technique without hampering his growth. So there are a lot of controversies of the choice of bone graft. That it can be harvested from the chin, it can be harvested from the calvarium, but cancellous bone marrow from the anterior ileum has been tested over years and it's given a very good result. So cancellous bone has got the osteogenic and osteoconductive and inductive properties, and the volume of the graft that can be harvested is good. And if it's done in a minimal traumatic technique, the results are fantastic. So that's about the alveolar bone grafting, which is done at 9 to 11 years. The next one is a formal rhinoplasty. Now, as a child grows, now the bony defects start showing up only when the child is 11 and plus. Now, at this time, we'd be seeing the mid face not growing so much, and the nose also deviating, and that's how the patients were present. And a formal rhinoplasty can be done at this point. Usually, secondary cleft lip nose deformity will have this kind of a look where the medial crural plates are displaced. There's no tip support of the nose. Alar cartilage is depressed and the lip is pulled up. So deviated nasal septum, they frequently have these nasal obstructions. So this is surgery done at 15. So, and finally, orthognathic surgeries. Orthognathic surgeries are the skeletal surgeries which are done after the growth completion is what I would put it, 17 years and above. Now, the most commonly done surgeries in this scenario would be the maxillary advancement, a Lefort or a surgically assisted rapid palatal expansion or a distraction. What I would suggest in this kind of patients is that depending upon the discrepancy, a single jaw surgery most often is not very successful. A combination of a bijaw surgery with osteotomies is better. Or if it's a single jaw is what is preferred, then a maxillary distraction is what would be advised. The reason is the palate is extremely scarred and the chance of relapse is extremely high. So also we have to keep in mind when the palate is advanced surgically, there is also a problem of velopharyngeal incompetence again developing, because when the palate is advanced anteriorly, the soft palate also moves along and that can create velopharyngeal incompetence. So to that, the orthognathic procedures are further modified. So currently the recommendation is that to do only an anterior maxillary distraction where anterior maxilla is moved without hampering the posterior velum. So So I would summarize the entire chronology. The lip and primary rhinoplasty, which is done at the age of 6 months. So I say primary rhinoplasty because when we do a lip repair, the entire nasal skeleton and the cartilages are repaired. A palate repair is done at the age of 9 months. Velopharyngoplasty is done at the age of 4 to 5 years. A lip nose revision done at the age of 6 to 7 years, or depends on the patient and parents' perception. Alveolar bone grafting done from 9 to 11 years, and a formal rhinoplasty at the age of 15 years, and orthognathic procedures 17 and above. Thank you very much.
Thank you, sir, for taking time and sharing your experiences with us. Now yeah. I open it for questions. Before that, to share the CMC experience, I request Dr. Pinky to say.
Good afternoon, sir. I'm Dr. Pinky Pradhan, HOD, plastic surgeon, CMC. I think the protocol that you have shown, we are following same here in CMC only. But thing is, patient in CMC or this area, they belong to very poor families as such.
Okay.
So most of the time they are presenting late to us.
Okay.
You're saying like lip, we are doing it is to be done by 6 months. Mostly they are presenting to us after 9 months.
Okay.
And palates, mostly they are coming after 12 months. 1 year age has crossed.
Okay.
So a little bit of variation, what we are
doing. Yeah, that's fine, ma'am. 9 months is the earliest is what we would say. But even 12 months is fine. Even 12 months is no big deal. I mean, still we can do that.
Okay.
But anytime before 18 months is the limit where we lose good function. After 18 months, we do a palate repair and, the speech is not really so great. So 9 would be earliest.
What we are lacking is a follow-up with our patients because they are very poor. So we do the cleft lips here, palate here, and bilateral, unilateral both. But what happens when it comes for secondary bone graftings and all those things, there's either they are lost to follow-up, main reason behind the financial crisis with them.
Yes, ma'am.
So that is why we are collaborating with our fellow team here of orthognathic and orthodontics and pedodontics, so that we can set certain protocol and we can help these patients.
Yeah.
We can guide them at what time you have to go to which doctor and what can be done.
Yes,
because most of the time they are of the opinion they are done with the lip, cosmetic part is done. There is no hole in the palate. The thing is done. So I think they have no idea about this graftings, bone graftings and orthognathic or rhinoplasties, that we can make them much more better.
Yes, true.
So this is required here. And I think both of us, both sides of the teams, we are facing mainly the financial parts.
Okay.
So if we can do something with that, I think it will be helpful for our patients.
Dr. Indrajot,
our vision was to collaborate with you. So last time I met you, I told you that I would be requiring your help and we will be doing together some procedures.
Definitely. Be more than happy, sir.
So we are working like that. And I hope that our dream will come true. And with collaboration with the plastic surgery CMC, Dr. Pinky, she's very enthusiastic and she always make us do, and we always contact her for certain procedures also. So ma'am is quite helpful, and I think we can make a good team and follow the cases and do the cases. And I would like your help too, to encourage and to do the surgeries, and with good results we can come up and do much better. Thank you.
Sure, sir. Thank you, sir. Thank you.
Anybody else with a question?
Joe, there is one point I wanted to highlight regarding the cleft lip and palate examination. When a child is examined for a lip and palate, the examination is complete only when the uvula of the child is completely seen. So most often, a lip is a very visible deformity. It can be clinically diagnosed from a mild distance, but we should make sure that mouth is open and completely the uvula of the child is seen, because there's a condition called a submucous cleft palate, which is most often missed. It's a misdiagnosis. Even the parents miss it because the overlying mucosa looks absolutely normal. So unless we see the uvula of the child, and if we notice a bifid uvula, and if it looks a notched palate, that's a submucous palate, and we should, diagnose it and not miss it. So that's a point I wanted to share. Yeah.
Thank you, sir.
Yeah.
Now to thank our speaker and all present, I request our Vice Principal, Dr. Shaila.
Hi, ma'am.
Shaila here.
Yeah, I know. Good to see you.
Thank you for the wonderful presentation.
Thanks, ma'am.
Maybe next time you can highlight on the pre-maxilla. Sometimes we get a lot of patients on pre-maxilla hanging separately.
Yes.
Many times we get patients where maxilla has been rooted out.
Broken. Yeah, I know.
So maybe how to deal with such kind of patients and
Yes.
what to do about the surgery thing.
Yes, ma'am. Sure.
Yeah.
This is basically, you're talking about a bilateral cleft lip.
Yeah.
So a bilateral cleft lip is the premaxilla, which is advanced. It's protuberant. It's like a sticking out.
Sticking out. Yeah.
Yeah.
Yeah. So
Yeah.
we have patients like this.
Okay.
The premaxilla is joined to the lip directly. The
Yes,
premaxilla
ma'am.
is joined to the lip directly.
Okay.
So,
So they will have the posterior arches completely collapsed. They will need some bit of expansion as much as possible, and they will need bone grafting. They will need stage bone grafting, and then we can take it from there.
yeah, okay. Thank you so much. Thanks
Yes.
for the wonderful presentation.
Thanks. Thank you.
Once again, on behalf of everybody in CDC and CMC, we want to thank you for taking your time and being with us. I now request AB sir to.
Yes, thank you, Dr. Manoj, and each
My pleasure. Thank you very much.
for this excellent presentation. And we are glad that so many of our alumni could join. I can see so many of them joining from different parts of country, and even some from outside joined. Thank you all for joining. And this is the first in series, and very soon we have one presentation by Jasprit Kaur, and then followed by Madi. Everybody knows Madi?
Yeah, yeah.
Okay, so he will be presenting in after some that will be the third in series. So we are thankful to the team from, particularly from the team from plastic surgery, which they took time, and so we will soon have a combined cleft consultation and team effort in planning the treatment, so that we don't miss any important milestones which the surgery needs to be done at the right time, and the other treatment plannings. Thank you all.